My name's Norm. I'm the chapter secretary for 94. Ash Ramamurti is the president, and Amy Dukovic is the vice president, and Jeff Steinhorn is our faithful video host. And thank you, Jeff, for putting together the Zoom for today. Today we have a longtime friend of our chapter as our guest speaker today, and there'll be plenty of time for questions and answers. His name is Dr. Jim Dwyer. Dr. Dwyer is currently a cardiologist specialist, a cardiologist in Prescott, Arizona, with over 43 years and counting of experience in the medical field. Dr. Dwyer has more experience with adult congenital heart conditions than any other specialist in his area. He graduated from St. Louis University School of Medicine Medical School in 1978. He is affiliated with medical facilities in the region in Arizona. He is accepting new patients. He has many years experience as a clinical cardiologist, adult congenital heart disease, general heart disease, interventional cardiology, and much more. Dr. Dwyer also wears many hats. His other hat is he is the co-founder of MediBlurb. MediBlurb is a physician-directed organization viewed as the authoritative strategy to briefly announce important information regarding health and wellness information, both in cardiology and other areas. Also to announce the latest advances in medical care and research, reports pertaining to medical devices and pharmaceuticals. He works very hard. He and his co-founder work very hard to make sure that the information on his podcast are trustworthy and highly respected. Many of us here have actually been subscribers. It's a free service to the MediBlurb podcast for quite a while, and we encourage you all to subscribe to it if you haven't already. Dr. Dwyer has some remarks on the latest topics, because that's what he does every week with these, what's in the news. He's got some background on what's going on. And after his remarks, he'll take questions and answers for as many that you have. Now, one other point, Mended Hearts, with the onset of the pandemic and for the indefinite future, our monthly support groups are all virtual. They're done by Zooms. We do not give medical advice. That's something up between you and your doctor. People should ask questions, are encouraged to ask questions of general interest to heart patients and families at large. This program is being recorded. It's will be edited, lightly edited, and many of our programs, and probably this one, go on our YouTube channel as well, so other people can share in that. So don't give out any personal information about yourself to maintain confidentiality. And with that, Mr. Ramamurti and Ms. Dukovic, do you have anything to add to that? If not, we'll go to the speaker.
Yes, sir. No, thank you very much for the nice introduction. Welcome everybody to our monthly support group meeting. I let our Vice President, Amy Dukovic, take over from here. Amy, it's all yours.
Okay, I don't really have anything to add, Ash. I think for the summer, we're going to just do with our board, from what we decided at our board meeting last week, we will just do private support group with no speakers over the summer. We're figuring it's going to be tough to get speakers. So next July and August will be support group only. And that's it. Alrighty, Dr. Dwyer, we are
okay. Well, Norm made me sound like an amazing guy. I'm just a regular guy. I was an interventional cardiologist for 30 plus years, did stents and started in the early days of balloon angioplasty way back in 84, 85, done 25,000 cases in the cath lab, did pacemakers and all that for 20 plus years too, until electrophysiology really came in vogue. But the other thing, my hobby is for many years has been health literacy. And I went to broadcast school back before I left St. Louis years ago. And since then I've done health general health information segments for radio here in Arizona, do weekly segments and for general health information. And so I love teaching people, but I'm not a Mr. Know-it-all, don't have all the answers. Anyway, and I've done professional recording. I did cardiology news for Frontline Medical Communications out of New Jersey for a year and a half before they were bought out by WebMD. I think they were paying me too much. They didn't want to pay me the same. So I recently restarted that weekly cardiology news segments, and you all may find that interesting. They're posted on the MediBlurb website, and it includes references for all the topics. I don't make stuff up. I use resources that, based upon solid medical research. So anyway, Norm had given me a couple of ideas. I thought I've got a number of topics listed, probably way more than we have time for, and please feel free to interrupt me any moment during the presentation. And all these topics, actually, if you go back to the MediBlurb website, the cardiology news podcast dating back to last month, you can find all these on there and look up and read more about the topics. Norm had mentioned some interest about the COVID. That's probably been talked about a lot. I thought the only thing I'd start out with was talking about the concerns just in the news recently about myocarditis after the Pfizer vaccine. And it's a very interesting topic yet to be better understood. There's just a recent article that's coming into publication at the American Academy of Pediatrics. And there's a great editorial written by Dr. O'Leary at University of Colorado and a Dr. Maldonado from Stanford. That's a preprint available. And basically, it's talking about a series of 7 adolescents, ages 14 to 19, who developed symptomatic myocarditis after the second dose of the Pfizer vaccine. There was also a report from, I think, based upon the Israeli army recruits, and actually, obviously, they're very good at nationally following situations there. And in Israel, they saw, what was it? I think 275 cases of myocarditis following vaccination from December 2020 to May 21 but that was out of more than 5 million people vaccinated. But it's raised some alarm bells, and it's yet to be determined. It's still in the stage where the American Heart and other organizations are still strongly recommending vaccination in adolescents. But the concern is that the way especially this new paper just coming out, that there may be some causal relationship. And the reasons that they cite in the editorial was, first, there was consistent timing of the symptoms developing in the 7 cases in the US, and it was after the second vaccination dose, and it kind of suggests a uniform biologic process. And the clinical findings and laboratory findings in all the adolescents studied suggest a common etiology. And there was no evidence of any circulating viral infection, respiratory viruses at the time that are more of a common cause of the myocarditis. There's a possibility that maybe it's actually related to the first dose of the vaccine, because the thing with the COVID-19 infections with kids, called multisystem inflammatory syndrome in children, usually occurs about 3 to 5 weeks after the COVID infection. So they wanted to make sure in further analysis that's potentially not actually related to the first vaccination dose. But the bottom line, right now, nobody understands the situation enough with the vaccination, but it's going to continue to be thoroughly investigated, and we'll see where they end up. Bottom line, so far, it's very, very rare, and it's still thought that the benefits of the vaccination far outweigh the concerns about the myocarditis.
Doctor, do you think, I'm sorry, do
Go
you
ahead.
think for adults fully vaccinated, with the vaccine who have heart disease should still continue to wear their masks as a precaution?
Well, I'm just a simple cardiologist. I guess my personal opinion is, and other people would disagree, I don't think you necessarily have to wear the mask if you're fully vaccinated.
Even those over 65?
I've got lots of people I'm seeing in my office in their 80s and even 90 that are coming in now not wearing their mask. And I asked them if I can leave my mask off during an office visit since I'm vaccinated. If they prefer I leave it on, I leave it on. But I think it has to be a personal decision. But I think the protection, once you've been fully vaccinated, the odds of developing an infection that's going to end up putting you in the hospital or causing death would be extremely rare from all I've read.
Even those with heart disease. Okay.
Even those
Thank you.
with heart disease, I believe. But
Mhm.
best answer I can give you is talk to your own doctor, see what they have to
Okay.
say.
Thank you.
So the myocarditis it certainly can happen related to the COVID infection. And that's, it's why do people get myocarditis from COVID-19? It's probably a combination of a direct viral insult to the heart muscle cells, but also in part relates to your body's own immune response to the muscle that's infected. So it can be difficult to diagnose when there's a myocarditis related to COVID-19. I'm not talking about the vaccination now. I'm talking about the actual COVID-19 infection. Imaging techniques can be helpful. Talk about echocardiography, other blood testing, biomarkers, and symptoms. But there was an interesting study. I'm trying to remember where's my list here? There was MRI study done in athletes, Big Ten athletes, and they found, I think they studied almost 300 athletes, and they did biomarkers and other testing, evaluated for symptoms, but they found out that the ultimate test really was cardiac MRI in detecting the inflammation. And actually, if they didn't do the MRIs, they would have missed the myocarditis in the majority of these athletes. And it did make a difference in how some of the athletic programs then ended up keeping their athletes away from the rigors of full athletic activity until their heart did improve. So any question on that part so far? Okay. So the CDC did come out as far as getting back to the COVID vaccine. I did do a little segment. Let me pull that up. It was in the 520, my news segment on May the 28th. Let me pull up the actual comments that they made. So the CDC alerted all healthcare professionals about this possibility of the myocarditis. They commented, the cases of myocarditis after vaccination it can occur both in adolescents and young adults, and it was more often occurring in males than females, and it was more frequently after the second dose. So it's yet to be determined, what the cause is, but I think as far as you all that are attuned to health information and that, not only thinking of yourselves, but if there's other family friends or younger people in your families that do suddenly have a problem after vaccination, make sure you encourage them to not just brush it off completely. Usually it's a short lasting thing. I don't think that there's been any catastrophic events related to the kids that came down with the myocarditis after the vaccination. But the CDC did talk specifically. The vaccination is highly recommended for everybody with the cardiovascular risk factors of high blood pressure, obesity, type 2 diabetes, those with heart disease, heart attack, and stroke survivors, because all members of those groups are at much greater risk of having an adverse outcome if you did get the COVID-19 virus itself. So probably most, if not all of you have been vaccinated, but if you haven't, it might be something to think about a little bit harder and talk about with your physician. I certainly pray to God that some other weird side effect doesn't occur in a larger proportion of us years down the road. But time will tell. I did see an interesting fellow in the office 3 weeks ago, who told me the story of 2 days after his second vaccination. He went into a thyroid storm. He had had benign thyroid nodules known by he and his physician for quite a number of years, and there was no concern about it. Thyroid function was normal, but very interestingly, 2 days after he received the vaccine, became hyperthyroid. Subsequent testing showed that his one or more of his what looked like benign thyroid nodules were suddenly hot. And the last I saw, he had been scheduled for a thyroid biopsy. So, the immune system certainly gets stirred up in various ways with the vaccine. And being a new approach to it, there's certainly a lot that we don't know. The next topic, if nobody has any questions on that, next topic that's sort of near and dear to my heart is, have you all heard the term microvascular angina? Has anybody ever heard that one? It doesn't sound like anybody's owning up. Well,
Yes,
for
I've
many
heard of
years,
it, Dr.
I'm sorry?
I've heard of it.
Great. Well, it used to be many decades ago, way back when I was in fellowship, it used to be called Syndrome X of the heart, Syndrome X of the heart. And it was because it was so mysterious and poorly understood that they didn't know what to call it. Fortunately, let me pull up my notes on this next topic. Come on, pull it over here. All right. 1 second. So it's thanks just within 2 or 3 years ago, there was an international group that got together called the Covadis Group that decided they really wanted to get a better handle on this microvascular angina. It had been thought that it was pretty much a benign disease that mainly occurred in women. And little was known because nobody had kind of worked out clear-cut diagnostic criteria. But finally, in 2018, this group, Covadis, which stands for Coronary Vasomotor Disorders International Study Group, came up with the criteria to make it more clear for physicians, cardiologists, and others to try and make a diagnosis and then to figure out how to treat it. People with microvascular angina can have chest discomforts similar to those of other types of angina, heart attack. There can be shortness of breath. Sometimes most of the time, actually, the standard tests on the patients, including echocardiograms, EKGs, coronary angiograms, don't detect any significant problems. And over the many decades, basically, microvascular angina had been left undiagnosed and untreated. A lot of people, primarily women, were told that they they didn't know what was going on, and it's probably nothing, don't worry about it. But that's really not the case, because the people with this kind of syndrome can end up in trouble at times. The chest discomfort is caused by the very, very tiny vessels that supply blood to the heart. And it's not from the big vessels on the surface of the heart. So an angiogram being done, they could just see mild to moderate coronary artery disease and nothing obstructive. And so that the usual cause of angina is written off. But this international group just finished a study, published a study after recruiting almost 700 patients from 14 institutions throughout the world. And what they ended up finding was that these patients clearly diagnosed with microvascular angina during the 1 to 2 years of follow-up, events of significance occurred each year in about 8% of the patients. And the events included hospitalization for unstable angina, non-fatal heart attack, and even heart failure. And there were even episodes of cardiovascular death. The interesting thing of this international study was that they clearly showed that men and women were equally affected by microvascular angina, and that the prognosis was truly no different between men and women, and no relationship to ethnicity. So if you ever know of a friend or family or whatever who they're not wanting to be sick, especially, and they're having this ongoing trouble, they need to become better educated, and maybe help even educate their docs to look for this. So the symptoms can be the same as other types of angina, but there are specific diagnostic criteria, which can include sometimes objective evidence of ischemia seen on EKG or testing, and then there's actually evaluation that can be done during cardiac catheterization that can identify the dysfunction of the coronary microvasculature. There can be what's something called reduced coronary flow reserve. You can see evidence of microvascular spasms sometimes. There can be a thing called coronary slow flow. I saw that many, many times out of the tens of thousands of cases thousands and thousands of cases I did, that we saw, and we sort of knew, this is probably what's going on, but didn't really have any way of pinning it down. So it is something that everybody needs to keep in mind. The treatment for the microvascular angina is still yet to be clearly determined, and that's hopefully will be something that this Covatus group will help discern. Basically the pathophysiology can be multifactorial and can vary from patient to patient. Various medications that can help. Some anti-atherothrombotic treatments, including statins, can be helpful. ACE inhibitors, angiotensin receptor blockers, and low-dose aspirin. Nitrates can work in some people. And there can be usefulness even of beta blockers and calcium channel blockers. So I became interested in this many years ago, probably, 30 plus years ago, when a family member was having troubles, and they really couldn't find anything, but she found out that she could feel better with using sublingual nitroglycerin when she was really having bad spells. And in part, in her, may have been in part hormone related and things, but I became a true believer that there was something else going on with the heart circulation, other than the big arteries of the heart, coronary artery disease being the culprit. So I think it's something.
Why was it more in women?
Well, that's what I said. People used to think was I don't know. I don't know why it was thought that for many decades, but apparently it was. But this new study says there really is no difference between men and women, and maybe the guys just brush it off uh, to some degree easier than the women. I don't know.
Or they don't
And
report it to their
or
doctors
they
as
don't
much as
report it.
women do.
Yeah, I mean, we certainly I see that all the time where a lot of guys don't tell you anything until they're near death practically. Um,
Mm.
and there was another study that's in one of my news segments from April the 30th. I think it was out of Sweden, where people were coming in, actually were doing cardiac MRIs on patients within, I think, 48 hours of hospitalization with what seemed to be unstable angina. And their CAS didn't show much, and but they had the cardiac MRIs done, and actually the MRI study can help show evidence of this microvascular ischemia. So even though the big arteries are clean, if the MRI is done quickly, they had done another study. The same group out of Sweden had done another study a couple of years ago where they did the study, I think, within 30 days, but they found out now in this newer study that doing a cardiac MRI within 48 hours, I believe, was really what picked it up more readily. Let me tell you if I can find the statistic on that. No, I don't have that right in front of me. So anyway, very, very important topic. And a lot of people out there having chest discomfort of undetermined cause. It may well be this microvascular angina. I've treated people empirically over the years, just, spending time with them and knowing them in the office, knowing they're not kind of emotionally distraught and or crazy or something looking for attention, but people with real discomfort, and empirically using these various drugs. I've personally had a lot of success. I typically have used the statin and ACE inhibitor, and a lot of times I've used more calcium channel blocker, vasodilator effects, with a fair amount of success, more than the beta blockers, sometimes the nitrate. So it does make a difference, but there are specialists pretty much at the university centers that can do the more sophisticated testing on the coronary microvasculature to make this definitive diagnosis. And now that the Covadis group is publishing these studies, I think hopefully more and more cardiologists in general will come to appreciate it. The bigger problem may be to getting the primary care docs to understand this problem to a greater degree. I don't know where you guys live, but here in Arizona, we have a lot of nurse practitioners practicing primary care on their own. Some of them are superb, excellent. Some of them are not so superb. And I'm not sure how well they understand this disease process and the nuances of and not everybody sends their patients to specialists, and some specialists don't even pay attention to these things either. So you guys, it's important in meetings like this for you guys to better understand and help spread the word and read up about it. The microvascular angina thing is mainly on my cardiology podcast from May the 28th. So references will be there. A lot of the times the actual journal articles listed. Most of the time there's a news summary on the articles and the research that I think certainly you guys could understand pretty easily. It's certainly not written at a fourth grade level, but those are written at a level that most people can understand.
So just to clarify one thing, doctor, so the the angiograms could come back clean, showing no blockage, but the cardiac MRI for someone with unstable angina within 48 hours could show the problem, correct? With this,
yes,
and
that's
so that
exactly
would
correct.
be what you. So that would be the key to ask your primary care if you're having symptoms, to ask for that
I
test.
think to ask about, primary care, to make a referral to a cardiologist and perhaps somebody who they know has an interest in microvascular angina. There are a lot of people where well, how do I say this carefully? There are even some cardiologists that would blow it off. So sometimes you have to be persistent and you have to keep asking and not
Well,
get
that's the
blown
only
off.
way that I handle situations is persistence. That's my key character trait. And my parents taught me never give up and
That's
keep the
great.
faith. Those are my 2 character traits. So thank you. And resourcefulness.
That's
So
great.
thank you.
So yes,
Thank
the
you.
MRI, they are MRI, but cardiac MRIs are, not necessarily done well at each and every institution. So that's the other trick, is making sure that you have a study done at a place who knows how to do it well, and the proper cardiologist or radiologist that knows how to interpret those properly.
Yeah, oh boy, you're absolutely right. And last question, sir. For those that are allergic to statins, or just what do you think of the new cholesterol drug, Repatha? It's fairly new. The one. Yeah.
Sure. That's a great question. And let me pull some stuff. I pulled some information up here. Let me see if I can
Thank you.
find that. But yeah, I cheat a lot because I used to have an associate, or still have a friend associate, who's not too far from where I work now, who is a cardiologist, but he's a board certified lipidologist. And anybody I get into a difficulty with a cholesterol treatment, I tend to punt to him to let him really direct the treatment beyond statin therapy. I did it early on because it was so difficult for me to play the game as far as getting the insurance companies to approve the treatment with the other agents, the various PCSK9 drugs. And somebody like a lipidologist can really play that game well. And those can work wonderfully well. So it's, and there are some newer drugs too, but and some of the insurance companies are covering those better. A lot of times they can be used with statins or without statins, but getting the insurance companies to pay for it is the trick. And it can be, oh gosh, last time I had somebody tell me about it was, $500 or $600 that they may be having to pay every month. So it's ridiculous. There's a newer drug, and I probably, it's also expensive, but again, a lipidologist knows how to play the game, or because of his stature as far as being a board certified cholesterol specialist, they can get the insurance companies to cover. There's a newer drug called bempedoic acid, and that's it's called bempedoic, BEMPEDOIC. And I think it's just finally was FDA approved in 2020. My friend had been part of the research trials of that for a few years, but it's now officially approved, and they're called ACL inhibitors, adenosine triphosphate citrate lyase inhibitors. And they actually work a bit differently in the liver to actually block the production of cholesterol. And they can be used, in conjunction with lifestyle changes and even with statins to lower the cholesterol. And getting back to your question,
is it for someone that's allergic to statins, though?
It can be, yes. Yep.
Mm-hmm.
And
okay.
So if you've got, and sometimes getting patients to lipid specialists, sometimes they, depending upon how many statins the patient has had trouble with, sometimes there's going to a lower sort of strength and lower irritating statin like pravastatin, which is sort of low potency and can be tolerated, sometimes combining a very low dose of a lower potency statin. And there's another drug called.
I'm sorry.
He's he has muted himself. He doesn't realize that. Let me ask him to unmute himself. You need to unmute, Dr. Dwyer. Yes, you muted yourself. Something.
Oh.
Okay.
All right, sorry. So can you hear me now?
Yep.
So ezetimibe, Ezetimibe, is also known as brand name is Zetia.
Oh,
That's
yes,
been-
I'm familiar with that. Yes.
That's been
Yes,
around.
that's a good one. Yeah, that's a very good one. Yes.
And a lot of times if somebody didn't tolerate some of the more potent statins, but can do okay on pravastatin, but we haven't gotten their LDL quite down to where we want it, then we'll add the ezetimibe to them. And sometimes that does the trick.
Yeah, I'm familiar with the Zetia. Thank you.
Mr. Farr had his hand raised. I don't know if he had a question or not.
Yeah, I do. Thanks, Norm. Doctor, several months ago, I was taking about 100 nitroglycerins a month. After I'd eat dinner, I'd have to take one about every hour, and that's the only thing that would kill the pain. So that kind of got me wondering about your microvascular angina. But after I had my Botox shots in my throat for my Jackhammer diagnosis, I don't take them anymore. So that may be because I had some pretty bad reflux and GERD.
Were you
And,
having did the doctor think you were having esophageal spasm?
Yeah, it would tighten up. I almost passed out because I
Oh my
couldn't
gosh.
breathe and couldn't get the water out of my throat. But my one of my cardiologists just turned off my LV lead in my Medtronic 3-wire because it has a fractured thing on the lead. So they gave me that because they said I had congestive heart failure in 2019 in December. And the new cardiologist says I needed that for health protection against sudden cardiac death. So you pay $40,000 for a device and it doesn't work. That's
Oh boy.
something else.
Well, yeah, it's, the old story is, if the chest discomfort responds to nitroglycerin, then the two things to think of in the old days was, angina related to significant coronary artery disease with obstruction of flow down the epicardial coronary arteries, the big arteries, or esophageal spasm. So it's very well known and described that nitro can relieve esophageal spasm. So it sounds like that's what was going on.
Sounds
with
like
you.
it.
I've
Yeah, my
never heard
last-
of it. That Jackhammer is a new one on me. I hadn't
Yeah,
somebody described it
right.
that way before.
My last nuclear stress test that confirmed what Dr. Gilbert told me about 4 or 5 years ago, that the apex of the heart is getting ischemic because of a very, very small vessel. And they said, have another heart attack because it can't be intervened with. So that'll be my 7th one coming up sometime.
Oh boy. Well, a nuclear defect at the apex of the heart a lot of times can be actually artifact. So, but depending upon what your known anatomy is, that can be very difficult to interpret. If the nuclear is read as an apical defect, sometimes it can just be related to an artifact, and it does not always mean coronary disease, but you can't just write it off without knowing the anatomy, especially if somebody's having symptoms.
Yeah, well, thanks. I guess I'll find out sometime.
Well, is all your chest discomfort gone since you had your esophagus?
I've got a little
improved?
bit, but it's on exercise, so I know that's heart related.
Yeah. Well, I would not, if you're having any symptoms, it's always better to talk about that with your doc and
Yes.
decide.
Yeah,
And a lot
yeah.
of times, there's if it's small distal, if it's the very end portion of the LAD, the front artery, and the vessel's too small, yeah, that can cause that small apical defect. And yes, you can't easily intervene on a vessel. I stopped doing stents about 4.5 years ago. And I think at that time, the smallest stent was 2 millimeters in size. And a lot of times the distal end of the LAD is, 1 to 1.5 millimeters. So it's just too tiny to put a stent in. Maybe they've come out with some smaller ones, but they don't always tend to heal well and do well, even with the drug coating on them sometimes.
Yeah, the LAD was bypassed as one of my 5 in 2000. And I think it's the only one still open.
Well,
So,
then you've got to pay close attention,
oh yeah,
and you can't rely upon the symptoms to always let you know how bad the situation might be in there. So, if somebody's been fine and then all of a sudden they're having even just mild discomfort, I usually just consider jumping on that sooner than later, if the person's of the mind to do something more than medical therapy.
yeah.
So
Well, thank
there was another study, and I don't know if I wrote it down here, but there was the ischemia trial, and they just published an update on the ischemia trial. And I don't know if you've heard about that one, but that's been years ago when they're looking at large groups of people treated between bypass surgery, stenting versus medical therapy. But basically, the bottom line is that if somebody's having angina, you don't necessarily have to have a procedure. That
right.
look at the 5-year mortality rate in people that people can do just as well over that period of time, and looking at the big group on medicines versus surgery versus stenting. So it really, if it's an unstable angina situation, well, then obviously doing a procedure can make a difference if patients continuing to have chest discomfort despite medications, but it won't necessarily in everybody improve the 5-year survival rates.
Well, I've got 10 stents in me now, so
Oh my goodness. Okay.
I'm sure the drug has already gone off all the stents.
Well, the drug is gone usually in basically 6 to 12 months, at least.
These are
And
22 years in.
then, but what the working of the drug is to prevent over aggressive scar tissue buildup over the struts of the stent during the initial healing phase of the first 3 to 6 months. You want scarring of the metallic struts of the stent to happen, but you don't want it to aggressively build up that it ends up growing into the inner channel of the artery and really blocking the inner channel significantly. So that's where and most of that it's well done. The full healing in most people is within the first year after a stent's put in. There are certainly exceptions, but if a particular spot in a heart artery that had a stent put in, if it hasn't re-narrowed down within the first year after that stent's been placed, then probably that particular spot's going to stay good pretty much for good. I mean, there are some instances where plaque can reappear in a stented area, but that's not so common. So that was the advantage of the drug coating on the metal struts of the stent. Just putting a plain stent in that encouraged a more vigorous scar tissue buildup through the struts of the stent and narrowing the channel. So that was a big improvement.
Amy Dukovic has a question or
Great.
comment.
So Dr. Dwyer, in folks with this microvascular disease and or people who have like intractable angina. Do you have any thoughts? I know it's been a controversial treatment over the years, but do you have any thoughts on EECP with those patients?
Sure, that can help. One of my early offices here in Arizona, we did get our own EECP machine, and I had certainly seen probably 70 to 80% of people improve, some very significantly improve with that therapy.
What is
It's
the ECP, please?
enhanced external counter pulsation is what it stands for. And
Thank you.
I don't know if you've seen any pictures of it or heard about it, but it's basically putting like giant blood pressure cuffs on both legs from thighs down to above the ankles. And it's timed to rapidly inflate and deflate according to your own heartbeat. And so it deflates when your left ventricle is pumping. So with the QRS, which on the EKG, the QRS represents the contraction of the left ventricle. So with the QRS, the cuffs quickly deflate to allow the forward flow out of the left ventricle, out into the arterial system. And as soon as that ejection fraction has finished, then the cuffs rapidly inflate. And theoretically, what's happening is that rapid inflation is causing blood, in a simple sense, to get pushed backwards up the arterial system, back up the aorta, forcing more blood down the coronary arteries, enhancing the flow, the pressure of flow down the coronary arteries before the next heartbeat occurs. And it's thought that that somehow may probably stimulate the microvasculature to relax and allow better flow. It's really not going to improve significantly the blockages in the big arteries on the surface of the heart, but it may allow the microscopic flow to reroute the flow down or to the vessel downstream from where a bad blockage it is. So yeah, I've seen clinically it worked. I'm not sure if they've done more studies since I last read about it years ago to really figure out the pathophysiology. But I saw some very interesting things happen to some patients. I still remember one guy who'd had a stroke years ago, and didn't have much feeling, I think, on the right side of his body. And he had, angina that just wasn't responding, didn't have any options for any other stenting or bypass surgery or whatever. But within a month of the EECP treatment, he feeling pretty well came back in the region of his stroke. Had other guys talk about improvement of their erectile dysfunction, people that had improvement of vision. So it's not just doing something to the coronary microvasculature, but it's probably helping flow other areas of the body in some way. I mean, I didn't see a lot of cases like that, but I definitely saw a number of people, and probably 75-80% of people, their angina improved significantly. But I'm trying to remember, it's usually, I think, it's 5 days a week for 7 weeks, I think, is what Medicare allowed, and you can repeat the treatment.
Any other questions? Anyone have questions?
I have one more unless someone else does.
Actually, I had a really brief one for Dr. Dwyer. Dr. Dwyer, just going back to your podcast, and you work really hard to have timely topics and everything. What's in the news, everything. What's the coming attractions? What will you be doing podcasts on over the next couple episodes, would you say?
Oh, I just scan everything over a few days and just pick stuff current. Really don't have, next week's lined up yet. I'll do some looking later today. One quick thing, Norm, that the people might be interested in. I mean, TAVR is huge these days with the aortic stenosis, and the transcatheter aortic valve replacement really is now taken over open heart surgery for replacement of the aortic valve through that surgical procedure. But I did run across something that I think your group needs to remember and promote among friends and relative. One is one of my podcasts. I can't remember. I think it was from May the 14th. You might want to look at that. One is it's about TAVR benchmarking at I think 300 to 400 institutions across the whole United States. And they came up with some criteria to really ensure that the quality is there. And unfortunately, there was about 11% of the institutions across the US that did not meet good benchmarking. So if somebody's is going to have a TAVR done, make sure they ask the questions and ask about, how many the physicians have done, if they participated in the national database. And if not, you really want to go to some place that you're going to be sure is doing it well, which I think about 90% places across the country are. About 8% of the institutions were noted to be superlative. And that brings to mind, there was another thing. Has anybody ever heard of basilica relating to TAVR procedures? If somebody's got a real bad valve, crusty valve, that, a high risk patient, if somebody has been being told that their TAVR procedure is ultra high risk, then you need to ask about basilica. I actually interviewed some docs from Emory about a year and a half ago, and that was the first time I'd ever heard of basilica myself. And it's part of the TAVR procedure where, basically when you're putting in the TAVR valve, it's crushing your old valve that's left in place, and they can predict some of the time whether the left coronary aortic cusp is going to end up pushing against the left main opening. So obviously that's a bad thing if part of your crusty valve gets pushed against the wall and obstructing the flow into the left coronary system. Well, basilica is a way, before they put the TAVR in, there's an electrified wire that they actually go down through a catheter and actually make a slice in the aortic valve, the old aortic valve leaflet on the left side. So when it gets crushed and pushed against the left coronary main region, that it leaves an opening so that you don't obstruct the flow down the left main. So that's really a cool procedure. The people at Emory had been doing it for quite a while. I'm sure there are it was an NIH study that they were participating in. I'm sure there are a number of other patients, but I think it's very important, even though it's become an everyday sounding kind of procedure to have a TAVR, you really need to make sure somebody knows what the heck they're doing. And if there's a high risk component that's even mentioned, to ask the questions, or is there someplace else better that you could get a second opinion from? So
Sam Dayes, who's a heart transplant patient member, has a question. Sam.
Hi, doctor. How are you?
Hi, Sam.
Good to meet you and good to see you. So I was a long time CHF patient before I was blessed with a heart transplant. So I'm just curious, are there, new or fancy therapeutics or treatments that nowadays people are being able to manage their CHF, longer until they absolutely need an LVAD or, even a transplant?
Well, it's still a fight for a lot of people. They thought that you probably heard the name, a relatively newer drug, Entresto. They were pushing Entresto and being better than maybe using the ACE or ARBs and spironolactone. But then a study I just read within the last week or two, Entresto in a big trial really was shown not to have any huge advantage. So I've got to read that data carefully. I don't want to disrespect Entresto, but it was a little disappointing what I initially read. So it's really, it's working hard with the medications, and there's still no magic. Whether we'll understand more about we're coming to understand that the right heart, usually the right heart had been sort of written off as being not as important as the right ventricle versus the left ventricle, but the right ventricle is really an important entity. So whether there's going to be some assist devices for the right heart and the left heart, and LVADs, they've certainly, the technology has improved compared to, certainly 20, 30 years ago, but there's no magic, whether there's going to be some improvement in the genetics of it or the cellular metabolism that'll get better understood, where you can promote your own DNA to start healing the heart. There are some studies that suggest that there's stuff along those lines that people are still researching and having some success, but I'm unaware of any major breakthrough.
Yeah.
One quick thing. How about, other monitoring things that you can put in addition to ICDs and, CRTD devices and stuff like that? Are there other monitoring devices that can, help?
You mean as far as, monitoring as far as rhythms or?
Yes, rhythms and,
okay. Well, that's one, that's very interesting. And I don't know much about it, enough about it, but I just did a segment this past Friday in the Cardiology News. It's a very cool device that measures, hold on, I'm going to get this wrong. Let me pull up the thing here. And it's called, oh, come on.
Is it MIMS or something like that, or?
Well, it's the PAPP CardioMEMS, and it's CardioMEMS HF system. And I just did the thing about this last Friday. So if you go to the website, you can pull it up, and there's a great article, news release from the University of Virginia Health System about this study. And one of the guys there at University of Virginia really did the initial research on this measurement called PAPP, and it stands for pulmonary artery proportional pulse pressure. And basically it's and using this device, it's able to monitor the pulmonary artery systolic pressure, the pulmonary artery diastolic pressure, and by subtracting those two numbers and then dividing it by the pulmonary artery systolic pressure, it gives you this PAPP reading. And back in 2016, they showed that people with heart failure with reduced ejection fraction and pulmonary hypertension, that if the PAPP was less than 0.5, it was associated with increased problems like death, heart transplant, need for left ventricular assist device, and heart failure hospitalization. Well, in this new study, they put in this CardioMEMS thing, and it's basically a tiny little thing that you put out one of the pulmonary arteries. You go up through the vein in the leg under in a cath lab, and they just release it into the pulmonary artery, and it wedges in place, and within a month or so, scar tissue forms around the edges of it, and it doesn't move. It's small enough that blood is flowing by it vigorously, but it's able to give a constant readout of these readings. And by them following this on a regular basis, they showed that by treating the patients and keeping the PAPP, above 0.583, above 0.6 or higher, that it actually reduced the risk of death by 46%. during 2 to 3 years of follow-up. So I was blown away by that. I read about it some few years ago, but didn't know much about it, didn't know where it stood. But it's very exciting. So by using that as a constant monitoring of the patient, adjusting diuretic therapy or other medicines to try and reduce the pulmonary artery pressures, it sounds like that may help people and
Awesome.
maybe
Awesome. Great.
delay. So I
So
recommend
Dr.
you look at that.
Now,
So
I-
I just interviewed with that company a few months ago, and there are some very interesting, so that technology has been around since the early 2000s.
Mm-hmm.
And now that they were bought by a couple of different companies, I think St. Jude bought them, who is now
Yeah.
Abbott. Their biggest challenge, I bet you could guess, but their biggest challenge is reimbursement.
Well, I think
The
seeing
insurance
studies like
companies,
this.
by insurance companies?
Yes.
Yeah. So yeah, it's now owned by Abbott.
Uh-huh.
What I read, but you know, I seeing data like this. If you can keep people out of the hospital and diminish, you know, heart failure hospitalizations, I think before too long you'll see the insurance companies agreeing to do that, because that's mighty expensive when people have to go in, and you know, these people can be sicker than anything at times, like Sam knows.
Right.
And the
Well,
more
I think that's where the partner trial did a good job in getting TAVR approved, because there was a lot of data there about keeping these folks, even though they were very elderly and they may only have lived another few more years, they
Right.
were able to show very well that they kept them out of the emergency room.
Yeah, I think the TAVR's been amazing. But I mean, I've been in practice since 1983. I've seen a lot of advancements and amazing things over the years, and it's just fantastic how things can keep progressing. But
It seems
yeah,
like
so
TAVR's been the big game changer. I've been around cardiac. Oh gosh, I've been a cardiac nurse practitioner, administrator for over 30 years. And I would say this was probably the biggest thing besides the coronary stent. This was probably the biggest change in how we treat patients.
right. Yeah, it's been amazing. Seen a lot of people do extremely well with it, and very
Yeah.
frail people.
Amy,
So,
did you have another
but
question?
if you're a nurse practitioner, you know, a lot of the cardiology news things I do, I've been trying to figure out how to get it out there. I mean, it's you know, cardiologists will find it some interesting, but I think a lot of what I do really is geared towards general practitioners and nurse practitioners, even cardiac nurses, to get a better understanding of these things. So look at the MediBlurb stuff sometime, and if you can help some other people look at it.
Oh,
I
I'd
don't make
be happy
I
to. Yeah.
I don't right now. I don't make any money off of it. So I one of these days maybe I will. I've done some
Oh,
work for some
surely I will
people,
look at it. Yes.
but
Well, the
I
other
think it's
piece about
education. Education is the key. The more the patients understand, the more the providers understand, and you know it. And it's not just the cardiologists. I mean, the primary care have to do their diligence and be attentive and work on getting the patients to the cardiologist. And you know, and I have nurse practitioners do a great service and help a lot. Actually, Mayo Clinic here in Arizona has a nurse practitioner year cardiology training once they get their doctorate. And I worked with one of their graduates when I was up in Flagstaff, and she was smarter than a lot of the cardiologists I've known over the years. So, but the general practice nurse practitioners that are very widespread, especially places like here in Arizona, I think we need to educate them along with the patients to be aware of these things.
Well, Dr. Dwyer, you really have done a heck of a job educating us today. And I know what's that, Jeff?
I was going to ask a question if I can.
Sure.
Well, I was
Amy,
Yeah.
My wife's down at the pool, so
A quick
and
question.
the cat's leaving me alone, and the horse is
Yeah,
at the
but
barn. So
yeah, but your wife
ask
is
away.
yeah, but your wife is a judge. We want to make sure we don't get in any trouble. I know you're
Oh
right.
yeah.
The question I had, since I had a mitral valve repair, was that I believe that there's a way to repair a mitral valve without an invasive
Yep.
chest opening anymore. Have there been more improvements or advancements in that field?
Yeah, there's a lot of, that those guys, you got to get yourself to the right structural interventional cardiologist to do it, but you guys can really do it well. I've sent patients down to some people down in Phoenix, and mitral valve clipping. They've really come to a better understanding of who really can benefit and likely have a successful procedure doing it. But I've seen some amazing things happen. I had a guy that, he's not the healthiest guy, didn't take care of himself, and he was, been following his moderate to severe mitral regurgitation for some time, trying to get him healthier. I think he'd had previous bypass surgery years ago, but he finally was going into bad heart failure, and he had mitral valve clipping, and it was like they flipped a switch. I mean, within 2 weeks, the guy was really turning the corner. So yeah, I think that can work, not in everybody, and the people that are involved in making those decisions, just like they have the teams to make the decisions about TAVR candidacy and the risk. I mean, they've got people that get together and talk about the mitral valve stuff, and they're doing some variations of TAVR now for mitral valve disease. There have been some instances done. I don't know how many have been done for a TAVR type device for tricuspid regurgitation. So, it keeps expanding, but
in my case, the water's over the dam, but
yeah,
the thought here I have, I mean, I've been exercising. In fact, teaching aerobics for years before anything happened. I had a heart murmur. Is it possible, because my symptoms presented themselves in a way that misled many of the doctors, and I just sort of had stomach cramps, not necessarily, I had a lot of stomach cramps and lost 35 pounds in 3 weeks before they realized what the problem was. Is it possible that someone that's in a healthier state might present symptoms differently than someone who may not be? If they have severe mitral regurgitation, I don't know. I don't know what I'm talking about.
I mean, that's a good question. I mean, but it comes back down to that's one thing I pride myself on, is I'm very good at listening to patients, and it takes sometimes that few extra minutes to try and understand what's going on with what you already know about a patient. But with the mitral regurg, the most common symptomatology is shortness of breath because of the back pressure up into the left atrium, then that backing up into the pulmonary venous system, and then back into the pulmonary artery, then to the right side of the heart. And, in severe cases, you can get abdominal complaints easily from venous congestion in the abdomen, higher pressure in the inferior vena cava. But so it can come out different ways in different people. But you just have to, most of the time it's shortness of breath more than the abdominal discomfort. But
right. Thank you. Norm, it's up to you.
One little tidbit as far as weird presenting symptomatology, and I had to give this credit to the internal medicine doc. This was literally about 20 years ago in Cottonwood near Sedona. Had an internist send me this guy who was having exertional discomfort in his tongue. Didn't have anything in his chest, didn't have any discomfort in his neck or jaw or teeth, but just his tongue. And we decided to do a stress test on the guy, and it was a little abnormal. We took him to cath, and he had 95% lesions in the circ and the right coronary artery. And each time we placed the stent, in each of those spots and you're transiently blocking the flow, for a minute, he got his tongue discomfort. And I mean, it was just reproduced. I mean, it was the weirdest thing. I've never seen it again, but it's just somebody paying attention. And obviously that wasn't their first thought, but when you work through the process, you never know what you're going to end up finding. And sometimes it's talking to people. I just talked to this was a doctor just last week. This doctor was focusing on palpitations and actually was breathing more than anything. And he had left main stenting, and then he was seeing the specialist, and he ended up seeing a specialist in UCLA, and they came up with a diagnosis of this guy of myocarditis. And reading the test reports, I'm not really convinced that the guy's got myocarditis. I don't think they wanted to do a high risk PVC ablation on the guy, but nobody thought until he happened to come talk to me the other day, well, maybe your left main stent is getting into trouble and you're really having dyspnea related to that. And then more you talk to him, and, oh yeah, I'm feeling this little bit of tightness in my chest the same time I'm feeling out of breath, and here's a doctor, an older guy, but very intelligent, who was sort of misleading the direction of things in a sense by not bringing up things. And the last thing I'll mention on the fun thing, not so fun thing, but an interesting thing came out of NYU Langone that I recorded about the other day, about women having what they called in their news release a pink tax when presenting to the emergency room with chest discomfort, and how women are written off and not treated as well as men, and delay in their being evaluated or even admitted to the hospital. And it's a shame that it's that way, but I think that's very important. And the last thing, another little fun thing I did the other day, recorded. Has anybody heard of Chagas disease? No, I guess not. Well, I heard about it 40 years ago in my fellowship, and I said, I'm never going to see this. Or I was practicing in St. Louis, and this is a disease that's from Latin America, and it's a parasite that gets into the bloodstream, and it can lead to actually a severe cardiomyopathy condition or a digestive condition. And now with people emigrating from other parts of the world where it's endemic and coming to the US and other places, I did an educational thing on it, just a 2-minute recording, but it's caused by the kissing bug. And it's people getting just in contact with the urine or feces from this little kissing bug that's endemic in South America. Can lead to, and people that develop the chronic cardiomyopathy from the Chagas disease, 60%, I think 60% have a risk of sudden death from the heart complications. So there's a lot of stuff out there. And one last thing, this was another recent favorite, the Stroke AF trial. And this was very fascinating. I did a little thing on June the 4th, but you've probably heard about people having cryptogenic strokes. People have a stroke and nobody has any idea where the stroke came from. And they've done studies then on those people looking for unknown atrial fibrillation being a cause of the stroke. So that was well described years ago, and then you find it and you anticoagulate them and try and treat the AFib. Well, this study took people that had strokes, but the strokes were due to either carotid artery disease or small vessel disease in the brain. So they already knew where the stroke had happened, but they decided to take this big group of people and insert a cardiac monitor under the skin, or do usual EKGs occasionally, or wearing some external heart monitors. And they followed and they wanted to find out if these people could have atrial fibrillation and have that be an increased risk for them having a recurrent stroke after their prior stroke. And with an inserted monitor, they picked up atrial fibrillation of significance in 12% of the patients after following them for a year, versus only 2% with doing external heart monitors or periodic EKGs. So I think that's going to be a potential game changer. We'll see how much the insurance companies will give in to that kind of thing. But those insertable little monitors under the skin and the left parasternal region are amazing little critters. I think for a lot of people, if somebody's had if somebody has had a bad stroke, might be something for them to know about and have further discussion with their docs about, really aggressively checking to see if they have some atrial fib they don't know about. Anyway.
Apple has announced in the iOS 15 release that's going to come out, new Watch 8, Apple Watch 8, some additional monitoring things associated with studies that have been done for heart stuff. I mean, you don't need to dwell on that, but I mean, they are coming. I'm just, listened to the WWDC conference, and they have all kinds of very good health things coming out where if the hospitals or the doctors are using the right medical, Epic is not necessarily one of them, but I've just used it as an example, system, that the watch itself can actually send information or constantly monitoring information to the physician to look at, just a comment.
Yep, that's going to be helpful. And another Swedish study using a external monitoring device called the Koala had some very interesting data. It's called a red heart study, and how it was very helpful and actually reassuring for a lot of patients by having that immediate feedback to the patient as far as their palpitations and that, and looking at their phone and having an immediate artificial intelligence interpretation of their rhythm. So yeah, the technology keeps advancing and can be helpful in a lot of ways. But
Dr.
right.
Dwyer, this has been unbelievably terrific. Amy Dukovic has some brief closing remarks here. I just want to just squeeze in one thing. That last time you joined us, I think was about 3 years ago, one of our first virtual meetings of this type, when we had you on the screen. And I've been keeping a little bit of an informal record here, just a little bit of notes about what you've been talking about today. And I counted 9 items. I'm not going to read them all off, but COVID and heart disease being one of them. Mitral valve, what's happening in TAVR, some other areas where none of this stuff was even on the books, or barely on the books, 3 years ago. It just shows the incredible acceleration, the pace of change in your profession, and the importance of podcasts like yours and what you do to help people stay aware of what's going on. Your field is changing so unbelievably quickly. Thank you for spending time with us. Thank you also for spending time keeping the public better informed. Wouldn't you say, Amy?
Absolutely. I really enjoyed this. I actually think I missed the last time you were here, Dr. Dwyer, but I am thrilled. Being in the business myself, I've noticed a lot of these things, and things that you've talked about, I've seen a lot of. So I'm really very appreciative to have you here. We really enjoyed it a lot.
Well, check out the website sometime. There's stuff that you guys will understand or find interesting. There's a lot of general public stuff. I produce weekly radio segments, like I said, for Arizona. That's geared down for more general information, but most everything I do has the link on the webpage for the resource that I base the segment on. So you might find that helpful.
Okay. Yeah. Great. Yes, definitely will. And I'll get on that podcast and see if I can get a bunch of my colleagues to get on to and
Yeah,
start.
there's you can sign up if you really like it. You can sign up, and then I shoot out an email every week when I do the new cardiology thing. So anyway, thank you very much. I'll sign off and let you guys finish your meeting. You take care.